Um, Good evening, everyone. Welcome to our second webinar of C.R.E.A.T.E program. I would like to say thank you very much for your presence, for your participation, for your feedback from the first webinar. We are so happy to receive such an amazing feedback from the first webinar. And actually, this feedback gave us this great positive energy to continue our journey of learning together, sharing knowledge and expertise, and collaborating together to make a difference in the translation research. Um, I'm Bashar Musa, and today I'm very happy to introduce the second webinar of C.R.E.A.T.E program. So, as it has been mentioned before by Dr. Fathi Al-Awadi, the president of the Emirati Diabetes and Endocrine Society, C.R.E.A.T.E is an initiative that is a collaboration based on collaboration between University of Sharjah and the Diabetes Society. We consider it a very successful collaboration between these two entities, and we will be continuing our webinars for the first phase, which include about 6 webinars. So I would like from here to thank Professor Fathi Al-Awadi and all the faculty members who are helping us in this initiative from University of Sharjah and other institute. So I have some kind of housekeeping and structure just to make sure that the webinar today is smooth and productive. The webinar will be live streamed on the EDES YouTube channel. If you have any questions, you can drop your questions in the Q&A box, and please mention your name just to introduce yourself to us. The webinar will be available on demand on the EDES Institute, and we have the website in here. So the webinar is accredited, CME accredited, but we kindly ask all the participants to attend all the sessions and to fill in an evaluation form that will benefit us a lot when it comes to how to prepare our webinars in the second phase. So please make sure that you fill in the evaluation to get the CME credits. Okay, so today it gives me a great and special pleasure to introduce a very well-known figure in the field of diabetes and diabetes research, Professor Salah Busnana, who I worked with for more than 12 years now. And it's very important for me to say that he's the one who introduced me to the Emirati Diabetes and Endocrine Society in 2013. So, and since then, we've been working together in a very successful programs, and I'm very proud of this collaboration. Actually, this collaboration is representing what we're trying to share with everybody else. And currently, we work in a very successful programs related to MSc in diabetes management and University of Sharjah Diabetes Center. So Prof. Abusnana worked in UK since 1994, where he got his MRCP. Since then, he's been involved actively in diverse research and education programs related to diabetes and obesity, awarded with his MSc in neuroendocrinology in 1996 at Imperial College, University of London, where he continued his clinical and academic work at Hammersmith Hospital, and he granted PhD in diabetes in 2001. Awarded with C.R.E.A.T.E UK in diabetes and endocrine at that time, and since that time till today, he's been working in different fields in diabetes and diabetes education, diabetes research. He worked in different hospitals, in very well-known hospitals in UK, including London University Hospital, Guy's and St. Thomas Hospital, Brighton University Hospital, combining his research and clinical practice together to make a difference in medical education. From 2011 till today, he's been practicing in UAE, and he's been a director and leading several groups, and he led several positions in the field of diabetes. Currently, he's the director of University of Sharjah Center for Diabetes, as well as he's the director program of the Master in Diabetes Management. Also, he is deputy chair for the clinical science department at College of Medicine, University of Sharjah. He has an amazing list of published work, and he's been an editor for several well-known journals. He's a member of British Endocrine Society, Diabetes UK, European Society of Diabetes, American Diabetes Association, Association of American College of Endocrinologists, and Emirati Diabetes Society. Without any further ado, thank you very much, Prof. Abu Sanana, to be with us in this webinar. The floor is yours now.
Thank you very much, Dr. Bashaya, for such introduction, which will put too much pressure on me to produce something in this. And not only this, for such needing program, and I will, through my talk, you will know why this program is needed. Now, I think I'm able to share the screen. Okay, so I'll share this one. Let me just, please tell me if you
yes,
seeing my screen. Good.
Yes, I can see it now. Yes.
Excellent. All right. So what I will do, I've been given the task of turning clinical challenges into research opportunity. So I'm not an opportunistic person, but when it comes to research, yes, I am. And most of the work I'm going to talk about will be on behalf of the team or teams I work with in this country and outside. So what I will do now, I'll just take you through the agenda, which I will take you through. But before I start the agenda, sorry, I just need to get this rid of this, yeah, somewhere here, yeah. I want to take you through the agenda, and it's quite important for you to follow this agenda. I reassure you, please don't blink, because I'm going to give few parts, but all these parts are connected. So it's like a series. So if you miss one, it might be difficult for you to miss the other. And I want you to concentrate only on the first half of the talk, because the rest it will be stories, and story everybody will follow. But what we'll do as learning objective, I'm going to go with you to identify how clinical challenges can be systematically reframed into structural research question. And I'll show you some framework, how you use that and examples, okay? The second objective, to differentiate between pathways of clinical injuries, case report, audit, observational study, clinical trial, transition. I'm not going to mention all this, but at least I'm going to introduce you to the frames you use if you decide, for example, to do clinical trial, or if you want to do diagnostic study, or so all that, hopefully you will be able to start and do. And I'm sure all of you done this, but at least I'm going to put this together. Again, I'm going to show you some feasibility criteria, and to me, this is very, very important to evaluate the quality and relevance of the potential research. So usually when we want to do research, it's just not a research. We have to look at the bigger picture. So if we start right, and I'm going to introduce you to the criteria, which will tell you the feasibility through the final. We're going to integrate the research design principle into everyday clinical practice. And since I started long ago, I thought, why clinician is being moved away from research? And I said, well, when they talk about research, I feel a stranger. And this is what pushed me to go and do academic degree, MSc and PhD. And I think having the scientist and the clinician together, this is really enforce the research outcome. And again, unfortunately, when it comes to the structural training, when it comes to the mentorship, we are lacking. And that's why C.R.E.A.T.E is one of the important programs for those who they want to combine the clinical work with the research. So we have to ask ourselves a question when we do. So why we are doing research? Why it matters? I think, please concentrate on this slide, because if you got the slide, you will follow my talk and you will not blink. So let me start with the first box there. So unanswered question in clinical medicine. People, they think, us clinician, okay, we know everything. So when the patient asks us, if you see how many questions we answered, we have evidence for, is not too many. So what does that mean? Clinical medicine is a constant source of unanswered questions. Not only this, we absorb challenges, and those challenges we face in the clinical field, they are the potential hypothesis for research. Because when we sit and we say, okay, a student or those who do research with us, or even ourselves, and we say, okay, I need idea in front of you on a daily basis in your practice, if you just look carefully. Now I will tell you challenges, because my topic is challenges, but I will not leave you in dilemma. I'll try to give you the solutions as well. So when we talk from bedside to research, just take this or keep this in mind. 80 to 80% of research questions sparked by us clinicians, okay, we don't know, we have questions. But unfortunately, only 20% of what clinicians do is evidence-based. So 80% of what we are doing, and if you ask us why we're doing this, we lack the evidence for that. And when they ask us to answer, well, we don't have evidence for it. And that's a bit scary, okay? The second thing is the evidence practice gap. And this is all of us realize, but we don't stress on it every time. So patient received evidence-based recommended treatment only 50%, 55% of time. Why is that? Because the evidence, it takes 15 to 20 years to become integrated into the clinical practice. So if we're doing a study today and the study is successful, we should look for 15, 20 years. And that's quite right, because I've been through this. We done the incretin study. We start with rats back in 96, 97, 98, where we giving that to the rats. And I spent like 15 years practicing diabetes until I can see the incretins, GLP-1 receptor agonists in the practice. The biggest challenge is the following. And you know, when we go through the talk, you will realize this. So to deliver evidence-based, and it's cost-effective, and and again with high quality care, this is what will improve the practice outcome. But that's very challenging to get all these together, okay, without money, without evidence, so we have to make sure that we enforce this to get the outcome. So now we talked about the evidence. When we talk about the evidence, I think it's not only we have to look at the evidence, we have to make sure we understand those evidence. So when it comes to clinical practice, we develop the clinical questions. So we have questions, and I receive questions on a daily basis from my junior team or from colleagues or even from referrals. So what I do, either I know and I have the evidence, or I will say, well, let me search for the best evidence available to me. That's very, very important, because if you do that on a daily basis, this is how you strengthen your knowledge. However, it's not only looking at the evidence. You have to appraise those evidence. Is it right evidence? Does it make sense? Is it being reproduced? Is it a strong study? So this is it's 3 words, but it's a very important step to do for you to trust the evidence, because you're going to apply that to your patient. Then, when you are convinced, you implement those evidence to the practice, and this is how we increase the percentage of the evidence-based patient treatment. And we have to evaluate the outcome. So before we don't use the evidence, and now we are using the evidence, does that make any difference at the end? And this is what the question commonly I ask. I said, have we make any difference to this patient since he started following up with us till today. If there is no difference, that means we are not doing much, basically. Now, coming to the foundation, anything without foundation is going to slip. So what's the foundation of the research structure? Everything you start wide, then you go to specialized research, then you go to more interested area because you know better. But let us just give you 2 slides or 3 slides about the foundation of research. So let us say anatomy of research. We say anatomy of the body. Anatomy of research is what's made of. What's that? It's the set of tangible elements. Remember, tangible elements that make up the study plan. What's that? We start always with a question, research question. We make sure it's significant. It's a design and a study object and measurement approach. So those are the anatomy or the skeleton of the research. As I said, every time I say something, I'll put a challenge for you and for myself. The challenge is to design elements that are relatively inexpensive and easy to implement. That's challenging. And I think all of you agree with me. But let me take you through those steps. Research question. So the research question, what it is what's this study address? What's the study try to answer? And when it comes to the background and significance, this is an important question. When it comes to the significance of that question and background, where this question came from, then okay, then you go to the design, how the study will be structured. And every question needs different structure, time frame, the epidemiological design. Then it goes to the subject. Who are the subject and how will be selected? So when it comes to the subjects, that's the one you're going to study. Is this going to be representative? And that's why we have the selection criteria and the sampling design. Because later on, when you come up with the data, if those group of subjects which you have chosen, they don't represent the population you're going to treat, it will be useless because you can't apply it. Variables is something very, very important. Anything I mentioned on the slide is really important because those are the measurement will be made. What are they? Can you measure them? Are they trustable? Have they been proven before to judge the question you address, whether they are predictable, predictor variables, whether they are confounding variables? What confounding variables mean? They are things, if you come and say, well, this is the result, I say, well, we don't know because of the weight loss or because of the working on the beta cell, which one is right? Cardiovascular outcome trial saying, well, whether it's related to the direct mechanism effect on the heart or because of the other variable. So you have to control for those variables. The outcome variables is very, very important. They should be trustable because if I say, well, variable X, and you say, what's the proof this variable X will make me confident in judging the outcome? Statistical issues, all these needs to be done together because hypothesis, sample size, analytic approach, if you don't know how to analyze, and I see lots of proposals and study being presented to me, and I see 25 variables, and I say, okay, do you have any statistical test which will help you to sort those out? Do you think those variables we can control for the confounding effect of those variables? So if you do this together, you go back and you say, well, I can't do this. I should revise this and I should go through frame. The second thing when it comes to the research is the physiology of research, how it works. That's very, very important. So use a draw interference about, inferences. What happened in the study sample? The study which you control, and that's what we call the internal validity. And again, in the outside world, because you're going to apply this to the outside world. So that's what we call the external validity. And those two are really important. But what's the challenge here in this? The challenge is the design and implementing a study plan with adequate control over 2 major threats to these inferences, which is a random error, which happen by chance. We don't know sometimes, but the more careful when it comes to controlling the steps I've been through, this error will be less. And the systematic error, which biased, and thus we shouldn't be biased when it comes to the research. Probably when you look at this, it's confusing, but this is very, very important. So let us say, well, we have research question. Then we target population and phenomena of interest. All that come from the truth you are using from the universe around you, because this is where the question comes from. And you have target population, either inpatient or patient outside, or even epidemiological study. Then you have phenomenon which you have to explore out. So what you do the design. So till here, it's external validity. But when you start with the study plan, an intended sample, which you're going to choose, and the intended variables, this is what we call the study plan, and will be referred to the internal validity. Then you implement. When you implement, this is the actual study now. Those are the actual subjects who's been included, and those are the actual measurement. So when they finding in the study, based on the truth in the study, based on the truth in the universe, the outcome of that study and the finding of that study will be trusted. And that will will improve the external validity and the internal validity. Now, how we can take the challenges in the clinical field to the research question. Please concentrate here, because I'm going to give you examples which will take you from the question, and sometimes you come up with silly question. So you shouldn't be embarrassed about that, but you have to go through the steps to make sure it's a significant question, not a silly question, and probably you don't have to consider that. So bedside to the bins, talking about bridging this gap. I told you before, 70% of us report observing unsolved clinical challenge. We have a challenge, and more than often we don't know. Even simple case of hyponatremia, sometimes we don't know what's the cause, and we just treat. Less than 20% of those research project, only 20 of those, okay, they might go to the research to say, well, let us find out. Why is that? What's the challenge? The challenge or the barriers is the following, that we don't have time. More than 60% of the patient or the healthcare professional, they say we don't have time. We don't have like a structural training for us to be able to pursue the research. Because if you want to be a doctor, you will go through medical school, then you go through the training. But research, we don't have structural training for the research, unless you do an academic degree and you have to do different courses yourself. And from the survey published in 2019, only 25% of us, they have structural training for research. And that's why, for example, today, C.R.E.A.T.E is one of the important whatever seminars to hopefully fulfill this gap. What's the consequence if the other two boxes is not being sorted? The consequences: missed opportunity to translate real-world channel into evidence generation. So those questions, they will stay unanswered. And on the same time, we will not have evidence to pursue and treat our patient better. So this is what we want to do, and that's why this lecture or this program to have structural training, and we have to concentrate on mentorship and systemic framework. And this is what I will show you, how this will reduce those or bridge this gap. So let us look at here transforming the clinical observation into structural research question. So we're still talking about the question. And we're talking about the question, we always say, but we don't realize the meaning. If you ask good question, you'll have good answer. Everybody's saying that, but I don't think all of us understand what does that mean. So let us say observation. Okay, observation, what does that mean? That we have knowledge gap. We don't know this. So we need to translate this to the bedside problem to answerable question. I'm going to go through a framework called FENA, which will help you to do this. The other thing is frameworks for question formulation. So to formulate question and get yourself structure is just you sit and think. No, they are framework will help you, okay, to formulate that question. So here we have like 4 different framework, starting with BICO, which is B for population, I for intervention, and C for comparators, and O for outcome, and TD is the time and the date. And I will go through those. There are 4, but I'll pick 2, and I give you examples how you frame your question according to those frameworks. Then we come to something called taxonomy, and I think everybody's saying this word, but that's taxonomy of clinical question. So when you want to ask question, if it is about therapy and intervention, you know you will go through randomized controlled trial or systemic review, nothing else, if it is therapy and intervention. If you want to go for a diagnosis study, diagnostic study, you have to do diagnostic accuracy study. If you want to look for a prognosis for any disease, cohort study, and that you should do this. So which study I should do? You should look at what you are looking for, then straight away you pick one of those. Etiology and harm, case control, cohort design. So these are the study you have to choose when it comes to the clinical questions. Example of transformation. So for example, I'll just give you a quick, I'll go through specific example, but here, for example, challenge. I think this started with the diabetes and endocrine society, MRS, and us doing diabetes. So this is a challenge we face on daily basis, frequent insulin non-adherence in the adolescents with type 1. So if I want to frame this question and I see whether it's right or not, and I use PICO, I say in adolescents with type 1, that's the population, okay? What's the intervention? Does peer support intervention? What we will compare that with? That's C, compared with the usual education. And what's the outcome? Improve the adherence. Look at the A1C as outcome. What's the time? We need time. It's 12 months. So now you break down your question you have asked to possibly a good question which can be investigated. Now I will explain some of the frameworks. So FINA here, I will tell you a summary at the end, which something I'm against, but I don't want to say that now. So fee for feasibility. Can you realistically do it? I see lots of proposals who they come and they put like 1,000 the sample size. And I say, well, we are in a hospital with 200 bed. Where are we going to get this 200 samples from? So be realistic. Do we have the skills and the funding and the facility? So feasible, this is very, very important, whether you can do it or not, because the question of not what you want, what you can do. I'm not putting people down here, but I try to make sure that everybody is realistic. So this is what's feasibility and what's the F stand for. I, interesting. Is your question interesting? Because if it is interesting to the wider community and to keep the people with you motivated and it's publishable, everybody will help you out and that will show they will see the light later on. Novel. People, they don't like repetition. One important thing, sometimes you reproduce some results or probably because of different population, you want to see whether that work in different ethnicities, that's something different. But on the same time, or you're confirming finding in your community, that's okay. But it needs something novel about it. The other thing is ethical, and ethics is not the subject of this, but ethics is everything when it comes to the research, and not only research, the clinical practice, relevant. So if you come and do something for patients with diabetes, whether it will make difference, it's relevant to those because it's big sector when it comes to the patient care and future research. So now we will take two, PICO and SPICE, and go through the kind of tools which you can use from the problem to the research opportunity. So you know, PICO, when it comes to the what stand for population intervention comparison and outcome, and SPICE setting perspective. So they are different, and I'll show you at the end which frame you should use for each. The important thing is now you come with the structure, you come to the design, you want to prove that structure is right, that framework is right. So here is PICO. So when it comes to the population and problem, what problem you are looking for? What's the most important characteristic of the population? Think of that. Is that included in your question or not? When it comes to the intervention, what's the main intervention you're looking for? Is it treatment? Is it a diagnostic test? It's a procedure? It's exposure? Because that will make the future design much easier. Comparison, if relevant. So if you are comparing, you're comparing with what? the outcome, what the outcome you want or hope to accomplish, measure, improve, things which tangible you can measure. Those are different examples. Let us start one by one from the top. There are 5 examples here, Baker. So here, for example, if you look at the B, stand for patient population problem, and I, intervention and indicator, C, comparison. But look at the colors. So we put those colors to dissect the question you are talking about as example to the framework. So here, patient with diabetes from nursing home has recently been admitted with stage 3 pressure ulcers. It's a very common problem on his heel. The unit nurse have called you, okay, as healthcare professional or doctor in for the wound consult. What we'll do with this wound. You have to choose between 2, the standard moist wound therapy or the wound vacuum. So if you go back and you want to make sure everything is included and dissected, so when it comes to the B, we have the population is diabetic patient in the nursing home, and the problem is a stage 3 pressure ulcer. And if you want to go and look at the you're looking at the standard moist therapy, so that's the comparison. And the intervention is the wound vacuum. And the outcome is the improvement, which is one is better. Coming to the second question, which is the box just below the first one. You work in a big city hospital, an ICU, and you have mechanically ventilated patients. And sometimes they contract nosocomial pneumonia, which lead to costly complication, that's everybody knows, and death. That's the most common cause and death. And you want to know if raising the head of the bed. So the nurse asks you, if we raise the head of the bed, will that make the patient better to contract those infection or not, or the flat? And probably this is a very common observation. Do we have evidence for it? Yeah. So when you go and look, okay, so what's the problem here? Okay, mechanically ventilated patient, that's the population. The problem is pneumonia. And what's the intervention to raise the head of the bed? And what's the comparison with is the patient lying flat. And the outcome, of course, less infections. In the past, that's another example. In the past few years, your hospital has installed antibacterial foam, okay, dispensers. I think they, in every hospital, in all of the nursing units, you had nurses asking you, not only the nurses ask, by the way, I will ask, okay, whether we do the antibacterial foam dispensers or we should wash our hands. Which one is better in contracting infection when it comes to the effectiveness? But when you look and dissect the question again, so the hospital is the place, patient where the patient are, okay, or the environment, antibacterial foam, this is the intervention, and the nurses when it comes to them contracting the infection as a population and washing hands or the foam, that's the outcome. And I can go through the next 2 examples, okay, but I hear Dr. Bashir said this will be available. It's exactly the same if you go through the rest. And a simple question, I hear this before, 2-year-old male with burns on 10% on his body. Came to ER. And there is say, well, honey reduce, they can be used in those cases. Or the standard treatment was the Silvadine, which one is better? So you have all the elements when it comes to the BICU, and you can classify it and you say, well, this is a full clinical question I can pursue. Okay, now come to the SPICE, the second framework. So here it's slightly different because you look at the setting, define the context in which research occurs. Is it a location, its environment, is it a condition? And that's to provide background to interpret the finding. Very, very important. Population, specific group or individuals. So that's either patient, student, demographic, not necessarily patient. Intervention, as the other framework, action, treatment, procedure, comparison, what you are comparing with. Are you comparing with the alternative treatment? Are you comparing that with the controls? Or maybe you're comparing that with the baseline, and this is what we do in most of the clinical trials. So we see patients on day 0 and we apply the treatment control, compare that with the placebo and look what's happened later on. And evaluation of course, the outcome and the effect, and we see the safety issues as well. So as example for SPICE, for example, a study exploring the impact of pain, okay, the new pain management protocol. You know, surgeon, after they do the surgery, most of them, they post patient on pain management. I'm not talking on probably chronic pain management here, but anyway, any pain management. So if you come here, the setting is hospital for the SPICE. And this is where, as I said, the context setting, the place where is that. Prospective is the patient who have undergone surgery, an intervention pain management protocol, and compare that with your standard management. And an evaluation, the patient recovery time. They will move quicker, they will go home quicker, they will go to the toilet quicker. So this is now, I say, well, I think this question can be answered because it got all the element of the SPICE framework. Formulate the research question, how does the new pain management protocol, here is intervention, impact patient recovery times, evaluate compared with the standard pain management protocol in hospital setting from perspective of the patient. So when you come, for example, and tell any of whatever your supervisor or yourself, they will find all the answers they are looking for. So it's full questions here, full question, and you know it's answerable, you can do. So if you want to develop research altogether, clinical event experience is very, very important. So when you see patient, you have to be a very good observer, bedside observation, other data, unusual cases, don't just pass by. Think about those and make sure either you know the answer or look for the answer. Initial scrutiny, which is the background knowledge, is the key check. Not everybody can do research because that will provide you with the new knowledge. So you should have knowledge, you should read, you should be current, you should do the up-to-date. Developing tentative stress question, that's draft phrasing, which I showed you how to do it. The secondary, which is the methodology, finer, it's feasible, interesting, which I show you how to do it. The structure with the framework, I showed you 2 or 3 examples, and I showed you 5 examples at the beginning to frame the question. Then at the end, through those steps, you will come up with a final research question. Let me tell you something. It looks complicated, but to learn it, you have to learn this. But you can do that in your brain when you do it more than once. It will not take 5 minutes as to make the question clear. So here is the to know whether it's researched or not, because not everything we can research. Novelty, answerability, are relevance to the practice. So, and just this is to put these steps together. One, does it provide new knowledge for the clinically relevant problem? Yes. And thus you do that through FINA. Is it answerable question? Use the frameworks to see whether the element available, and that will make the question available. Would inform or improve practice guidelines. Every research we do, we should see whether that can be implemented as guidelines, which I will show you at the end. So the consideration need to be given in developing a good research question. You have to define that, the problem, what's that problem is, and I showed you the position, the research at the current stage of evaluation, early phase or later phase, and they are completely different. Are you just exploratory studies or ensure, explained that before, assess the feasibility and plausibility for the design of the study. So I give you lots of slides, but I would like you to remember this, please, okay? Unstructured frustration, because you become frustrated more than often, must be converted into structured research question to be testable. So just not get frustrated, this patient is not going to improve or I don't know what's going on. Please make sure that you can convert that to a structured research question as we have been through in the previous slide. I showed you BICO, SPICE, BU, and Eclipse. I always hate to come with those shorts but here it's not that. Are not just teaching acronyms, they are really globally recognized framework embedded in Cochrane's and NICE methodology. So something came out from evidence So they will help you. Different framework suits different type of question. And I told you this before, and I thought better to put it in this slide. BICO for therapy, okay? SPICE for surface delivery. BU, which another one, is for exposure. CLIPSI is for health surface evaluation. Those steps, this is what you have to keep in mind in the first part of the talk. Those steps ensure the research methodologically sound and fundable and publishable. That's very, very important, because if you do it, you know you are on the right step, and you know whether you can, people will accept and giving you the funding or not if you apply for fund. So bridging this into the study, you have to master the literature. Everybody come to say, I want to do research, and I say, okay, have you done a literature survey? Why is that? Because mastering the literature, it's really give a credibility of what you're going to do, because it might be, okay, it might be not, it's been done. You don't have enough knowledge how to do it. People, they done it and they found problems. You can say, stay current, that's up to date. Engage actively with informal conversation with the colleagues, because most of the questions come from queries and discussion. Prepare and connect. You have to prepare yourself and connect to the people who they will help you, and the reviews. Question assumptions. Always come up with a question. Technology update is very important because time is very important. Translational research, which is what we are talking about, is thought I'll put one slide, is the research bench to the bedside. So you see here 3 circles: laboratory research, then clinical research, then population research. And you see there is link between the clinical research and laboratory research. That's T1. That's what you call the translational research. Then the T2 is the clinic, is again translational research, but that's from the clinic to the population. You can apply it. That's what we mean by this. And this is what we've been talking about, and this is what the lecture about. So if we bring everything together before I go to the end of my talk, now the question emerged directly from my clinic or from my team, and those became publications. And I'll give you those examples and I'll tell you the right story. Those who they worked with me, probably they will realize this stories, and Bashir is one of them. So this is from my clinic as example. This is when I first arrived to this country. I used to work in a center for diabetes, and we used to look at patient Emirati nationality only. And I was doing outpatient clinic, and I'm new to the country. So one patient came with uncontrolled diabetes, and I said, well, it's probably due to the food she's eating. She's not listening. So I asked her, what do you eat? And she said, I'm eating rgag. And I don't know what rgag is. Is it English term or French term or what? And I said, what's rgag? She said, this is, so I didn't understand what's that. The challenges is too many for me here. So I picked up the phone and I called one of the consultants who's been working there. And I said, what's rgag? He said, this is a bread eaten by the Emiratis. And I said, okay. So how much carbohydrate in this? He said, I don't know. We have very clever, intelligent lifestyle dietitian. I called her and I said, how much carbohydrate in the rgag? Is it healthy food or not? She said, I don't know. So now the challenge is all of us, we don't know. And we're treating a patient who eating this, and we want to get them better. So I said, okay, we have what we called meeting on Thursday for research. And I said, I got the patient 1, 2, 3, and I think they are a challenge for us. So what we should do? Probably after discussion, we formulated the question and we said, let us look at the popular breads eaten by the Emirati population in this country and look at the glycemic index. And yes, we did. And we published this paper called the glycemic index of traditional type of bread in UAE. And what we found, surprise, because I want to blame my patient and say, well, you are eating bread, so that's why your blood sugar is high. And in fact, it's the lower, the rgag is the lower glycemic index. So it's better than the other 4 or 5 or 6 breads. So this is how we apply or we work and treat patients without evidence. And this paper being cited a lot when it comes to the lifestyle, whatever treatment, because there is no much study like this, and that's been published. Second example, okay? So as I used to work for a company, Swedish company, so we're doing business as well. It's not only looking after patients, and we were applying for a contract to the Ministry of Health to do bariatric surgery for a patient, and we got paid for that. So I was the one who wanted to put a draft to the Ministry of Health to get the contract. Then I start looking at the data of the bariatric surgery in UAE because I want to put that in the. We have outside data, but the ministry want local data. And I said, okay. I looked at the data at that time, talking about it 2011, 2012. There are a few scattered studies, but there are not too many. So, okay, very challenging condition. I don't have local data. We need to get the contract. We need to get the patient better. So what I should do? Okay, so we sit and we start discussing this, and I said, okay, let us, with the first contract, at least try to publish the data. What we have done, we've done a pathway for the patient. The day they start, the day they come, they go through all the specific steps in the guidelines, and we go by time, so we can publish this data later on. And we do the post-operative program, which we look after the patient. And guess what? We done it. Okay, I'm not going to explain this, just to tell you how framework in the hospital, okay, or in the center will help you in publishing papers. So this is what we have. This is probably one of the few papers being published at that time, bariatric surgery outcome single center study in United Arab Emirates. And what we have discovered, there's huge benefit for the population. This is the mean weight. You can see the reduction there. And this is the HbA1c and fasting blood sugar. And not only this, they drugs which patient on, those are different medication before surgery and after 3 months after surgery and 6 months, from 8,000 dirham to 380, then 340. So the Ministry of Health, they have the data to say, okay, we'll give you another grant to perform more surgery because it's beneficial. This is what their evidence needed for the decision makers and for the patient. This example, vitamin D. At that time, probably all of you like 2013, 14, vitamin D, it's everything. Then they start talking about the body composition on type 2. You say, well, the challenge here, conflicting results. We don't know whether it's good or bad. The same thing, vitamin D is very prevalent in this country, and that's challenging as well, but it's motivating because it will apply to good sector of the population. Most patients on vitamin D supplement. So that's the challenge, because if we want to do a trial, all of them, they are on vitamin D. So how are we going to control for those who they are not on vitamin D? We need strong study. So we decide, okay, to decide this with all those challenges, we should go for a randomized controlled trial, treat patients with vitamin D and those without vitamin D and see the outcome. And what's the other challenge basically is we want to screen for the patient because we want to see whether they are on treatment or not, and we want to have their body composition. So we do manual screening, and that's a problem. So we sat with the IT and said, okay, can you come up with a program or software which will help me to screen for those patients? And this is what they done for us. You just put the data you want, the type of diabetes, the gender, the characteristic, and you come up with this. So the challenge make us looking for solution, and this is the solution. This is what we have done. Then we were able to do the randomized control trial. You know, it's not easy. It's blinded, and we finished and we published this, and that was an important outcome study. As I said, there is no time to go through the specific study. I'm just now telling you how clinical challenge will go into research opportunity. The example number 4, and again, it's from the practice. We start talking about real world data after we have wealth of data and the electronic record. Okay. So, but there are too many challenges. What are the challenges? The challenges is that the data is not complete, and visits of the patient is not structured. So they come when they want, they go when they want, they don't go to all the clinic. So we thought, okay, now randomized controlled trials test something called can it work? But the problem with that, they test the safety and efficacy, but that's very selected group, okay, of that's they come and we keep looking after them all the time. They are highly motivated patients, otherwise they will not be volunteering in the clinical trial. But when it comes to the real world data, does it work? Because this is the real practice. This is a large, diverse number of in the population. And again, they come for standard care, then they might have kidney problem, liver problem. This is the real practice. So we thought, okay, this part is very important. So what we need to do to be able to perform real world data, we went for this is the pathway, how the patients. So if you have this pathway, you will be able to follow those patients or go retrospectively and see whether they drug, you can standardize them to the age, to the gender, to the medication they are on, to the lifestyle, to the care, and you go for the communication because you have all the data and you have the time point and you have pathway to go back and apply all those framework for. And not only this, every single clinic from the assessment to the nurse educator, it goes to one system, to the computer. So it's very easy to use the software I have shown you early to search for the data. So the work you do in 3 months, you can do that in 1 day because you have the tool to do it and you have all the clinic visits. Then we said, okay, now we have the patient treasure wealth, we have the data, but we have to structure ourselves to do research. So we came up with a research pathway as a team. And this is the research pathway. How are we going to do it? Steps. So that's regulate the research. And not only this, show the progress, what we are doing. And that's taken from all what I have shown you earlier. Then we said, okay, those research, it need policy and procedure and need documentation. And we done that. As I said, people who are listening, and Bashar said we started back in 2012. This is what we've been doing over the years. And we come with those policy and procedures, and we apply them in more than one institution now, probably 3. And after we got all this, we start easy for us to make publications, whether it's real world data, whether it's in this country, whether it's investigating common disorders, whether randomized controlled trial, predictive factors for perinatal depression among women with the gestational diabetes, because we have the data and we know how to dissect it, and we have the tools how to do it, and we trained ourselves and our staff how to do it. Then we publish scientific researches. Then we done the vitamin D again because we have experience with that. Then we come to the point and we say, okay, what's now? We are in clinical institute. We do research, but it's slightly limited. Why it's limited? Because of the following. Let me show you what we have till now. What we have till now is this: staff training and development. Yes, we do have good staff. Patient clinical pathway, we do have, and I showed you. Patient electronic record, okay, the IT. But this is when you sit and you put the hat of thinking on your head and say, where shall I go next? What should I do? And I say, okay, research pathway we have, a research policy and procedure we have, but still we are missing the collaboration agreements to make a big research. We have some collaborators, but not many, and we need facility. Why we need facility? Because we start thinking, have we done it? No, because there are still many challenges. We want to do more advanced research. We want to go to the lab research. So we start talking about what, okay, next generation sequencing, ion torrent technology. And you can see those sophisticated techniques, which I don't know half of them. Confocal microscope. Do we have this? No, we don't. So what we have to do? Shall we stop, or we look for opportunity and changing this challenge to another context? And what we have done, we went and we start the center in the University of Sharjah. Why this center is important? Because we try to include education, training, research, and clinical services together. And we have students who are the engine of the research. And not only this, we have the hospital, and we have hospitals basically collaboration wise. We have Dubai Hospital, we have Al Qasim Hospital, we have Rashid Hospital and University Hospital, and we have the Institute of Research, and we have us brains. So we can do the circle of translational medicine, which what we are talking about right now. And all this, our perspective is the patient. I showed you those. We can't do them before. We don't have them. But now the sky is the limit, because the Sharjah Institute for Medical Research, they have all the equipment and the protocols to do those protocols and those assays for us. And probably we use most of those. So now the thinking is changed. And that's why I think your life should be dynamic when it comes to research, clinical, everything in life. So what we should do now, we don't want to do a patchy research. We have to complete the circles, okay, the chain. We have to focus on one thing which we are experts in. So instead of we doing 20 things, let us focus on 4 or 5 things. And this is what we exactly done. This research done by, led by Dr. Bashir and the team, the diabetic neuropathy project in UAE, because we've done epidemiological study on this before. Okay, and I'll tell you how the connection happened. And we know inflammatory biomarkers, then microRNA and hypoglycemia, all this connected to the diabetic neuropathy, hypoglycemia and awareness, FOS, and novel differentially expressed gene. We have area and publication in all these around the. Then this is the important publication which looked at the identification of the novel differentially expressed gene in type 1 patient, which this showed collaboration with different partners in UAE, and at the same time that we progressed the research to try to answer question from different angle. And we add this is the auto and diabetic autophagy and the diabetic hypoglycemia. And what you need to work as a team, okay, now we should explore the inflammatory biomarkers more. Now we should look at it because this is the target of the treatment in the future. And we won't be able to do this unless we now putting everything together, integrate the clinical care. You have the research and you have the clinical care. And both of them, they should come together. Experiments, observation, then experiments, then the care together. And we have to implement them to the guidelines. So we start thinking of, okay, now we need to get the data because we have local data. Why we don't have our local guidelines? This is the first trial when it comes to the guidelines. That's the clinical practice recommendation. Myself and my colleagues, we for to treat obesity in United Arab Emirates. That's back in 2019. Then everybody got encouraged. And with the colleagues, we come up with the Emirates Diabetes Society Consensus Guidelines for management of type 2 diabetes, because we have local data, so we can come up with the guidelines. If we don't have local data, that we need to go to ADA, so we just implement ADA, but the co-founder here, it's a different population. Most of the clinical trial being conducted outside the country. We've been included lately in the clinical trials. Now we have this, and now we're going to publish the update in the coming endocrine society meeting here in UAE. Then not only this, patients with diabetes, they have cardiology problems. So I said, why we don't sit with the cardiology colleagues and come up with the cardiometabolic guidelines? I told you that need to be implemented as guidelines, and now, yes, we have it, and that's been done. So conclusions, Chairman. Toward the integration, I want you to concentrate on this, please, because that's very, very important, that integration of care and research. So the first box on the left-hand side is the clinical research, and on the right-hand side is the medical care. So in clinical research, we focus on population. In clinical care, we focus on individual. Generalized knowledge in clinical research, but in medical care, patient well-being. Average patient, this is in clinical research, individual patient. Research subject and researchers, this is in clinical research, but in the clinical medical care is the patient and doctors. Experimental conditions, this is in the research, but in the medical care, and that's why I have to be careful, is the research world setting. And it's the panelistic, whatever, research, and then physician authority. And physicians are very authoritarian. So here, real world evidence, comparative effectiveness, and patient perspective. On the medical care, it's standardized and guidelines. And this is what I showed you at then. Information technology and electronic health record. Defensive medicine. We do that quite a lot. Defensive medicine, what is that? If you don't do nothing, nothing will happen. They will not blame you. Some people, they say, I didn't do a mistake. Well, you have to work to do a mistake. If you don't work, you'll not do a mistake. And if you want to integrate all this together, patient-oriented research and patient-centered medicine, it's the evidence-based medicine and medicine-based medicine. So you put, for example, experiment and observation, research subject and patient, researcher and doctors, useful information and benefit of the current and future patient, quick application of research result, and autonomy and non. So what I would try to say here, those things, they should go hand to hand, because at the end they will mix. So why we don't think mix from day one to be able to apply? So generate knowledge and deliver benefit for both individual, patient, and the population at large today and into the future tomorrow. Tips for early stage clinician, for those who they just started. It's not complicated. Start small. Publish case report. Do audits. Use mentorship. This is very important, because people doing the research, they're doing because they are interested in. So you need to be mentored around. Collaboration is very important. Okay, more brains and more subjects. Align with institutional department priorities. Make sure what's needed in your institution, this is what you should go for, because this is what your institution been equipped for. Create rule, and thank you, Bashir, how the platform support clinician training, membership, and network. This is what we are doing tonight. So if you forget everything, take those messages with you. Early clinical challenge is a research seed. Simple observation can grow into impactful study. Encourage participant next time you face a challenge. Think research. Lots of people I have collaborated with. I can't mention all of them. I just gathered a few photos to show that what I have been talking about is work of too many people, too many brains, which I work with, and I led some of those. So I would like to thank all of them for what we have done. And now I will stop here and hand back to the chair, Dr. Bashir. Thank you very much.
Thank you very much, Prof. Salah. It is very insightful, very informative and enjoyable talk. And the most important thing is, like when you explain the holistic approach of what it takes to be a researcher and while you're working in the clinic, and how you put your priorities when it comes to the question or research questions, and how to use different frames to have a well-structured kind of pathway to start your research. And also at the end of the day, how to correlate between the outcomes to answer the questions that's related or going eventually to help in the patient in patient care, or to provide excellent patient care. Thank you very much for that. Now we'll move to the Q&A session. Please feel free to post any question that you have. Yeah, we already start having several questions. As usual, our amazing senior diabetes educator, Zainab, thank you for starting the questions. She's asking that sometimes I end up collecting too many questions, I assume, which makes the analysis difficult or too few. So this process, Zainab feels that it is very challenging and time confusing. So what is the top strategies that you recommend to have this right start? So you have a lot of questions, sometimes too many, sometimes too little. But to dissect that, it has it needs time. Sometimes it needs, like phase analysis. So how to overcome that by having a very clear strategies? Of course, maybe you have several ones, but she's asking about the first strategy, any clinical person in a team who found something interesting to use this strategy to keep doing research. This is the first question.
Yeah, very good question. I think this is one of the dilemma. Okay, when you come to the research, you think you want to do everything, and you have like 1 million questions you want to answer. But it's not a wrong strategy, but you have to make priorities. And the priorities is, for example, if I come with the million question will come under how I improve patient with diabetes as a control. So I want to find out what making them worse. I want to find out what's the best treatment. I want to find out what. So I write, for example, and this is what I do in early days. I write 15 questions. Then I start master what are the questions which they are close together, okay? And I put them in groups. So I say, okay, this is the first group of questions. Instead of 15, now they are 3 or maximum 5. And I say, my primary endpoint is question number 1. This is what my study should be designed to answer, because I want to power my study according to this. And on the same time, I want to make sure the other secondary, data is powerful enough to be further study later. Because if you have more than one secondary endpoints in the study, the important thing that can be converted later on to full study because you want to confirm this. That's number 1. And what will make you choose the first one? I think I went through different whatever advices. What will make you choose the first question first? And whatever you do to structure yourself, you go through those frames and choose if you are going for certain question. Let's go for those finer and BQ and the eclipses. The other important thing is when you think of too many variables, what does that mean? You are confused. Why? Because the more variable you have, okay, the more confusion will be. Because if you have too many variables, the confounding factor will be high. And confounding factor, you need big sample, large sample to be able to overcome this. Because you need to do stratification later on. And doing stratification later on make the statistical significance less. So what you do, let me establish the first strong question point, and then back to you, Zainab. If you collect too many data and you have too many, what you do, I said, that's absolutely fine. You put it in your computer, you sit, because you have the whole cake, and you start cutting that cake the way you like. Because if you ask question, let me see whether that question answer is available in the data I have. So I think you should sit down, look at what are the priority, make sure what's the question which is more significant, go through the structural way I have explained, make sure that the less complex design at the beginning will be easier to apply the statistical analysis later, and it will be, you can progress that later. This is what we do. Sometimes we have data and we divide it even in publication into 3 papers because we will have to address different points.
Thank you, Prof. Salah, for
I hope
that.
I confuse her more rather than explain.
Yes, it is. It needs a lot of convincing, to keep doing research. So it's not only about finding the right answer. We have another question from newly graduated medical student. She's asking, maybe I can answer this question because it's related how C.R.E.A.T.E will help, medical students or newly graduated medical students who have already some research question. So we started as I mentioned before in the first webinar, I explained how the program has different phases. The first phase is the introductory. We want to make sure that everybody is aware of the issue, and we invited people who've been through this journey before to tell us, how we think about it and how to start. In the second phase of it, we will be organizing different kind of training session, and we'll inform you about it. So the first part is about awareness, about introduction. The second phase, it will be about training, and at that point, definitely we can help you. Again, Zainab, I think she highlighted something to do with the variables, but I would say that the variables, it's again related to how you deal with the whole situation of having different kind of challenges in the clinic and in the question related to the clinic setting, and to take it from there. So they said, do you have any golden, I would say, tips for effective patient recruitment? Yeah,
Oh,
Dr. Salah.
yeah, okay. That's a very difficult task, to be honest. Okay. I think I said mentorship earlier. If you want to recruit patients, recruit consultant first. Because patients will not say no to their doctors, but will say no to you. So, and again, I can present the research to the patient in a way they will accept, and I can present it in a way they will not accept. We shouldn't lie to the patient when we recruit. We should tell them the truth, okay? But on the same time, we shouldn't scare them from the research. We're doing this, we're going to do this intervention, it might kill you. So you have to explain it in a good way to make sure the patient understand what they are going for, and at the same time, they feel it's safe and they got monitored all the time. But what happens sometimes, and I see that more than often, if, for example, Mondi's patient and the student want to do a research. So if Mondi helped the student to say, well, okay, we have a research and this working with me under my supervision, you are safe, and they're going to tell you about some study. Okay, they will say, okay, I'll give you all the whole blood in the corridor. But the issue, unfortunately, and the other thing to help recruitment, I think one of the things we might need to do in the future and create the need to do is the awareness, population awareness. Without research, we'll not be able to help you guys, patient. So very important to say you're not going to die. You know, that's the, and again, if the drug got licensed, it doesn't mean they are safe. They still have a side effect. So research is done in more controlled environment, not in like real world data when they have marketing drugs and they go away and they start using the medication. The other important thing, you have to be persistent. Probably there are 20 patients, you'll have 2 patients. But tomorrow when you come, you will develop the trick, how you convince them to. Without recruiting patients, you won't be able. The other important trick is it's really nice to screen before. So you come to clinic tomorrow. We have 2 clinics. For example, I'm talking about our hospital, 3 clinics, and you go through those clinics and screen what are the candidates. So don't waste your time for those who they don't fit your criteria. So if you want to spend time and talk, and when you come to the patient, don't come to somebody who's talking over the phone or he's angry, or and you said, can you come to the research? They might hit you. You have to be opportunistic and know which one will be, but very important to come and screen before. Come for the whole week and screen. And you say, well, Tuesday and Wednesday, most of my selection criteria in those clinics. I'll come and sit there and try to recruit this patient. What we do, useful tool as well, when they screen, they come and say, Dr. Salah, I have this list. Your clinic is whatever, 40 patients. I have 10 of them. They might be included in their study. So I said, okay, there's highlighted yellow. And I got my student outside or whatever researcher who want to take, and that's safe and you can do it. They will go with 50% easier than if you approach them out of nowhere.
Yeah, thank you very much, Dr. Salah. I think you highlighted a very important point by, the researcher. I think it takes to be a good researcher more than the scientific aspect. You have to read faces very quickly, and you have to be very intelligent dealing with people as well. So we have another a question. Reem, she's asking about which study design that you recommend when it comes to establish a clear policy in treating patients in different settings, outpatients clinic compared to hospital. So there is any specific kind of research design that you recommend for her to start working in a clear or establishing clear policy in treating patients?
So what policy she means? Is it
Uh,
testing one
mm,
medication
yes,
intervention? So
she
that's
didn't mention, but I
only
think she's,
comparison.
yeah.
Yeah. If it
Mm,
is only comparison, if you
mm.
apply the eclipse frame and you will do cohort, because you're going to look at patient from cross-sectional from the hospital and from the outpatient. And you will have, when it comes to developing the policy, you will say, okay, what's the policy will benefit? Is it going to benefit if we see those patients in patient, it will be more beneficial, cost effective, we'll do more blood tests, or that's waste of time and they should come to the outpatient clinic. So you have to identify what you are looking for, and it will be either cross-sectional for both or a cohort and follow-up. So those patients who they've been looked, for example, mild hypoglycemia, whether it's better that to make policy those they come to the hospital or they treated in outpatient clinic or even just education over the phone. And this way you will be able to decide and compare between the two. Obviously, it won't be a randomized controlled trial, it won't be systemic review, it won't be, but it will lie down cohort study. This is what the policy comes out from.
Yeah, we're still receiving many questions in the chat box, but because for the sake of time, we'll take the last question from our dear colleague, Prof. Basima, and she will be speaking in the next webinar. She's, of course, everybody thanking you for a very interesting and very informative presentation, including Prof. Basima. She's asking about, the early researchers. Often they have this fear of rejection from mentors. So what would you recommend for early researchers in identifying their niche area for clinical research? So there is any specific recommendation to help the young researchers identifying their niche area when it comes to clinical research?
Yeah, and I put one statement as takeaway message for the starters. And I said what you should start with. And that's very, very good point. Start with the case report. It doesn't matter what the case is, whether it's chest, abdomen, diabetes, hyperlipidemia. I will tell you why. Because the case report, the finding, all of them are there. And within 1 month maximum, you will be able to find all the information. When you start writing that case report, what will happen? You start thinking, okay, so those are the steps. What's the evidence behind that? What's where the research comes from, how I write the case, and you will be able to publish it because it's short. I know when it comes to the evidence is low, but this is the start. The second starting point is the audit. It's very, very important. So if you come, for example, patient, I'm talking about diabetes, those who they treated for diabetic ketoacidosis in the hospital following the protocol and how many they didn't follow the protocol. So you will be able to learn what research is, what's the simple statistical method to compare between the two, and you will learn the adherence and to stick to the guidelines. And you can follow that up after 1 year when it comes to the audit, after 2 years, and you will continue. Then you'll say, well, from my audit, there's very specific, interesting area. It's this. So this interesting area is this, and I'll follow that up as research.
I think we will stop here. We still have many questions, but we save them for further discussion in different occasion. Thank you very much, Prof. Salah, for your time and for your amazing contribution tonight. To conclude here, I would like to thank everybody who spared 1 hour tonight on Thursday evening to be with us. Looking forward to see all of you in our upcoming webinars. And as we mentioned before, all the certificates will be awarded based on the evaluation form that you will fill in after the webinars. Everything that we've been talking about, it's available on demand on the EDES Institute website. And all the details of the coming webinars is there as well. We have a lot of very interesting topics coming, and I would like to announce now, as I mentioned before, our next webinar will be on Thursday, 9th of October. It will be our clinical research, how we explore the spectrum of different study design by Prof. Basima Siddiq. After that, also we have more webinars related to the ethics and related to how to kind of discover and share your research when it comes to publication. At the end, I would like also to tell you that there is a lot of exciting activities going on at the Emirati Diabetes and Endocrine Society in collaboration with the American Diabetes Association, making diabetes technology works as a continuing education program. Thank you again, and we all hoping to see you on the EDIC. It is our popular meeting in February from 6 to 8 February 2026. So please be tuned for all the announcement related to this. At the end, thank you very much, everyone. Have a great evening and great weekend. We'll see you next time. Thank you very much.